Welcome back. I'm excited to start our afternoon listening session. At this time, I ask our presenters to go ahead and turn on your video if you haven't already. We have 4 invited outside experts to speak with us about nesting within population-based models. You can find their bios posted on the PTAC website along with their slides. After all four have presented, our committee members will have plenty of time to ask questions. Presenting first, we're honored to have Dr. Mark McClellan, who is the Robert J. Margolis Professor of Business, Medicine, and Policy, and founding director of the Duke-Margolis Center for Health Policy at Duke University. Welcome, and please begin, Mark.
Great. Thank you all very much. It's great to be back with PTAC and ASPE and see some familiar faces, virtually at least, in the room, and great to be on with such a distinguished set of panelists. If you go to the next slide, this is a topic that we at Duke-Margolis, like the rest of you, regard as both very important and also very timely, given some recent policy developments at CMS and high priority of addressing specialized care in the context of whole person care throughout our healthcare system. It's a topic that we've been working on for a while at Duke-Margolis, including in collaboration with other panelists here like François, Kevin Bozick, who are participating in this meeting. Would encourage people to take a look at some of these documents if they want to hear more detail about what I'm covering today. But with that, let me go to the next slide, which is the way we're thinking about the role of specialty care. And we were pleased that CMS adopted kind of a similar patient journey framework for their announcements this past fall and going forward on their specialty care strategy in Medicare. Throughout the whole patient journey, especially as you get to the more right side of this slide, but increasingly to the left, where specialized diagnostic techniques and early disease interception interventions are available, incorporation of specialty perspectives and specialty expertise is increasingly important in creating a whole person care journey that is effective. To date, we've seen some payment reforms to support efficient, high-quality patient journey, mainly focusing on acute episodes, where it says most payments or most alternative payment models that have been implemented to date. Bundle payments triggered on things like a DRG admission for a limited time period after a major procedure or hospitalization or major event occurs. What we're focusing on here is expanding that framework. And on the next slide, we think of this being very important because there are a variety of really critical types of specialized care. Much specialized care is delivered by experts in intensive procedures, in particular episode-contained environments. Hospitalists, general and specialized surgeons, their further steps to help them implement comprehensive data and safety systems like have been proposed by American Cancer Society and others are really important. There are other specialists, including such areas as nephrology, where the specialist really is the basis of a comprehensive medical home for a patient, whole person care, and there are payment models to address that in development and being expanded as well. What I want to focus on is this third category, going on to the next slide, of longitudinal coordinated care. What important as those other categories are, most of specialty care by dollars and by impact on populations involves interactions between specialty care and other providers, particularly primary care groups and advanced primary care groups, in delivering care for chronic conditions such as cardiovascular disease, musculoskeletal conditions, diabetes, metabolic conditions, dementia, lung diseases, inflammatory bowel disease, serious mental illnesses. The list goes on. Here, we don't yet have the implementation of policies and payments that support integrated longitudinal condition management, including engagement with primary care providers that are participating in increasingly advanced accountable care and other arrangements. And so on to the next slide. In terms of starting these efforts, we would advocate starting with where you can get the most bang for the buck. So all conditions are important in terms of magnitude. There's the most experience, the most data in areas like cardiovascular and musculoskeletal care, respiratory care, already some models engaging specialists in longitudinal cancer care management, though I'd emphasize there, the episode models typically start with the initial major treatment for a diagnosed condition. They don't really address the diagnostic process, which involves primary specialty interactions, or the care for the increasingly large number, fortunately, of cancer survivors who need ongoing effective management, hopefully as conveniently and efficiently as possible for monitoring for occurrence and potential long-term complications of treatment. So we would advocate, as in the next slide shows, finding ways to support taking the limited resources that are in the blue category of these payments by specialty and finding ways to help them expand out. The blue category here is payments for base condition management as opposed to payments. So you can see the biggest part of these pies are going to major procedures, minor procedures, acute events. The episode payments we have now that are about acute events and procedures do drive more efficiency and hopefully more coordination within and right around those episodes. What we're talking about here is enabling specialists to participate and sustain models that shift more resources into avoiding the hospitalizations and the need for perhaps major procedures in the first place. A focus on the best longitudinal outcomes for the patient, and those best outcomes often involve or could involve avoiding hospital stays and major procedures. So the next slide. The idea we have for this is a notion called specialty condition models. We're not the only people to have thought of something like this, but we see this fitting into very well the CMS specialty strategy that's been articulated so far. CMS has laid out potentially a path to transitioning to mandatory acute episode bundles based on BPCIA, but mainly being hospitalization plus 30 days, which again supports optimization of care within the episode and complements the goal of getting all Medicare beneficiaries, and for that matter, just about all Medicaid and other Americans, into longitudinal coordinated care models. CMS recognizes the need to engage and support specialists in longitudinal chronic care models as well, and has put that on their long-term set of goals for specialty care reforms. And we see this specialty condition model as an approach to jumpstart that and maybe move up and clarify the implementation of that long-term goal. This would be a complement, really a nesting around the acute bundles for conditions that really are about chronic management, not just about management of the acute conditions effectively, and would be intended to provide support and sustainability for coordination of care and alternative care models that really are focused on maximizing longitudinal patient outcomes. The next slide illustrates how this might work. We have acute condition bundles now. We have whole person accountability bundles as well. You think ACO models, ACO REACH, et cetera, that have total cost of care benchmarks. Some of the challenges with doing condition-based benchmarks in the past have been that they weren't done in conjunction with accountability for total cost of care. That's why we view these models as appropriate for nesting, nesting in a way that might be voluntary for physician-led ACOs, where we could provide potentially templates and data to help guide their decisions and support for working with specialists on enabling longitudinal care coordination within their overall models, but potentially mandatory for hospital-based ACOs where the revenues are all flowing to them for patients anyway, both for the primary care and the specialty care for their hospital-based ACO patients, but they right now don't have the flexibility to enable specialists to, if they can, engage more longitudinally. The only revenues they get, unless they transition fully over to a capitated, risk-adjusted model, are primarily tied to more procedures, these DRG-based acute episodes, which doesn't enable so much financial support for the longitudinal models. Another way of looking at this in the next slide is showing showing also how the specialty payments can be, especially condition payments, can nest the acute event models and can in turn fit within, on a voluntary basis or a mandatory basis, the total cost of care models for physician-led ACOs and hospital-led ACOs particularly. And on to the next slide, some promising areas where a lot of work has already been done on this topic include musculoskeletal conditions. I think you're going to hear or have heard from Kevin Bozick and colleagues about degenerative joint disease models in this space, longitudinal cardiology care. We've worked, I had the privilege of working with the American Heart Association, American College of Cardiology on some of these concepts. CMS is working on a dementia model now, which also is promising from this standpoint. And PTAC has looked at a number of these models in the past, just not yet in the context of the CMS Medicare strategic goal of getting all Medicare beneficiaries into accountable total cost of care models and finding ways to implement these specialized care reforms within that overall context. So I have a couple of slides that I'm not going to spend much time on now in the interest of time that go through in more detail how these models would work. So an implementation pathway for condition payments that I would encourage CMS. We would encourage CMS to start using and developing shadow bundles for these leading conditions as part of their effort to implement shadow bundles related to BPCIA measures this year. That would mean making data available to ACOs and maybe more publicly for not just BPCIA participants, but all specialized care providers to get a handle on what's going on with care utilization, outcome type measures at the level of BPCIA for all providers to help jumpstart progress in adopting those models more widely. We really would like to see that include specialized conditions as well. I've talked about nesting measures. The development of these condition measures really facilitates the longitudinal patient-reported outcome measures that matter, like functional status for the conditions that I've been describing, or independence. And next slide, I've talked about transitions for several different types of beneficiaries, ways in which these models could work with physician-led ACOs on a voluntary basis and hospital-based ACOs. For beneficiaries in advanced ACOs, they've already moved away from fee-for-service, so this is less critical. And then finally, in terms of the next slide, short-term steps, implementing shadow bundles with reporting and data sharing to help facilitate the movement into specialist engagement in these longitudinal management of chronic condition opportunities, data sharing to support that, and align fee-for-service changes. Thank you all very much for the opportunity to join you.
Thank you so much, Mark. That was really interesting. We're saving all questions from the committee till the end, so please capture your thoughts and be ready after the end of these presentations to bring them forward. Next, we'll hear a presentation from Mr. François de Brantes, who is a senior partner at High Value Care and Incentives Advisory Group. Please go ahead, François.
Great, thank you. And it's a pleasure to be here and reacquaint with old colleagues. It's appropriate that I follow Mark because I'm always thinking of myself a little bit as Mark's understudy, and so I'm going to try to unpack a few of the points that he made. But if you just pull back and reflect on his comments, ultimately what we're all talking about is what ACOs, whether they're PCP or hospital-led, should actually be doing in engaging the entirety of the delivery system to become far more effective than simply focusing on what they do at a micro level and then, referring out and hoping for the best. So if we flip to the next slide, ultimately in a payment model, what matters to anyone involved in that payment model are these two issues of relevance and actionability. So it has to be relevant to me. Obviously, Larry doesn't do cardiology because he's a gastroenterologist, but he does everything associated to gastroenterology. So if you give him a basket of, conditions, procedures, et cetera, that need to be managed in gastroenterology, he's going to know how to do that. And his colleague cardiologists are going to know how to do that. And that's obviously the principle that we're espousing, which is leverage the expertise of the specialty care providers in optimizing care of beneficiaries. But of course, it also needs what you do. And when you get engaged in an alternate payment model, it's got to be meaningful. And by meaningful, it means it needs to cover enough of the costs of care of the patients that I'm seeing, that I truly am going to invest in the critical clinical reengineering. So if you flip to the next slide, I've taken a piece of what Mark showed and focused here on unpacking a little bit what Mark presented as being the entirety, or what we could calculate as being the vast, vast majority of cardiology care that Medicare beneficiaries receive. And this analysis was done using a very highly representative sample of Medicare fee-for-service beneficiaries. And when you look at that combination of procedural episodes, acute events, normal routine medical management, et cetera, base condition management, so think of base condition management of heart failure, coronary artery disease, hypertension, et cetera, it only represents a third of the total cardiac costs of Medicare beneficiaries. The other 2/3 are going into minor procedures, major procedures, and acute events. And the whole notion of specialty care management, just like the whole notion of primary care management, is to reduce the amount of unnecessary minor procedures, unnecessary major procedures, and of course, reduce the incidence of acute events. But if you focus the specialty care only on minor procedures, or only on major procedures, or only on acute events, it essentially misses the boat. And longitudinal patient management, these specialty condition models that Mark talked about, is taking that base condition management, but the entirety of the medical spend, and telling the specialty care providers, this is the nut that you have to manage. And the goal is to reduce the things that could be reduced because maybe it's low value care, or it's indicative of failures of care coordination. And so that's why we talk about nesting procedures, acute events underneath population-based management. And if you flip to the next slide, this chart is just designed to illustrate how this works in a sample of 5,000 beneficiaries, within which there are 2,000 who happen to have a variety of cardiac conditions. And then of those, 375 end up by having procedural episodes during the course of a year. And the numbers inside each one of these little rectangles represents what could be, for each one of these areas, a specific benchmark in actual. And so what I'm teeing up is the next slide, which talks about reconciliations and how these, go back up one, how these pieces, back one up, how the pieces fit together. But intuitively, you kind of understand that if you have a primary care physician who's managing 5,000 beneficiaries, some of them are going to have specialty conditions that can and should be managed by the specialty care providers. Why not have a risk contract for those specialty care providers? Why not fully engage them in the management of those patients? And within that specialty bundle, this specialty care model, we know that there are going to be procedural episodes. And so why not create benchmarks for those procedural episodes so that everyone along the chain, the proceduralists, the specialty care providers managing the conditions, and whatever the ACO is that's managing total cost of care, are all accountable for optimizing outcomes of beneficiaries. And essentially everyone's in the same boat, rowing in the same direction, which is different than being in the same boat but rowing in different directions. So the way in which, and this is, I keep reminding people when they, when I talk about nesting condition episodes, especially when people go, oh my God, it's so complicated. No, it's relatively simple math. It's pluses and minuses. It's arithmetic. So if you go to the next slide, I'll just give you a representative example of this arithmetic. You start typically at the base with the lowest unit of accountability, which in this case ends up by being procedures. And much like you would in a procedural bundle, you got a benchmark, you got an actual, you reconcile, and that reconciliation yields either a plus or a minus. And in this case, there's savings, and so the savings accrue to the proceduralists. Those who are managing the condition category, the specialty care models, that's the middle bucket. And in this instance, they also have a benchmark. By the way, their benchmark includes an expected incidence of procedure episodes, so it's in their best interest to reduce the amount of procedures to the extent that it's medically appropriate, because that's how they're going to generate savings, in addition to reducing the amount of acute events. So once you reconcile the procedures, you reconcile at the condition level. Once you reconcile at the condition level, you reconcile at the total cost of care level. And you know, I hear and I continue to hear the refrain from those who manage, you know, ACOs and hospital-based ACOs or even PCP-based ACOs, that there's just not enough money to share, and all we need to do is kind of refer patients out. And I think what this chart shows is that there's plenty of money to go around. I think we all know this, but if we really want everyone in the same boat rowing in the same direction, you need to create these contracts, these sub-risk contracts that really create this alignment of incentives across the delivery system. So the net effect of all of this in the next slide is that proceduralists are encouraged to optimize procedures. If we flip to the next slide, those managing the conditions are encouraged to do a good job, reduce acute events, minimize the number of inappropriate low-value procedures. And then those who manage total cost of care have a huge incentive to find the most effective, efficient specialty care providers. And this goes back to what Mark said, which is, of course, there's a concern, I think, from all of us that if you have a hospital-based ACO that has its own specialist, they may actually not be the best. They may think they're the best, but they may not actually think they're the best. And so as CMS and you all continue to deliberate on the importance of specialty care models, if this works well, then everyone is encouraged to optimize. And sometimes the best are not necessarily within the system; they're outside the system, and that shouldn't matter. Right, and so that's how when you set the benchmarks, when you set the incentives, you also encourage robust competition for value among specialty care providers. And I'll end on this telling you that I have witnessed this personally. I've been involved in deploying this model for the state employee plan of Connecticut, and it works incredibly well. And the primary care physicians work with the specialty care physicians. Those who manage the conditions work with the proceduralists. It absolutely works, and it's just a shame that it hasn't come to Medicare yet. That's it.
I was taking it all in, François. It was really interesting. Thank you so much. Next, we have Dr. Rozalina McCoy, who is Associate Professor of Medicine at the Mayo Clinic in Rochester, Minnesota. Welcome, and please go ahead, Rozalina.
Thank you so much, and thank you for the opportunity to talk about patient attribution, which I think is really at the core of all the models that we're talking about, but also one that is least defined and where I think we have the most uncertainty at this point. So it's truly an honor to be here today. While seemingly simple on the surface, I think attribution, particularly for patients with multiple or serious chronic health conditions, the manner of which really requires multiple touch points with healthcare providers and the healthcare system, is really not. So as we think about who is or are the accountable unit for a given patient, we can think just through who's likely to be involved in the care of one of my patients with diabetes. And I think diabetes is a great case because it really illustrates the complexity of attribution. It's truly a whole person disease with complex, multifaceted treatment regimens and complications that affect every single organ system, requiring the engagement of multiple specialists. So for a person living with diabetes, they may be seeing a primary care clinician who may be a physician, who may then be supported by an advanced practice provider like a nurse practitioner or a physician assistant. They may see an endocrinologist. They'll then need to get assistance from from a pharmacist, both acutely to starting new medication and then longitudinally to help with dose adjustment and fix their other medications as their kidney disease status changes. They may need assistance at home, working with community paramedics or community health workers who may or may not be part of the same organization. They'll be seeing dietitians, nurse educators, a psychologist. They'll be touching base with their care team nurse, trying to coordinate it all. So you really have this army of people working to support the patient, but how do you know who is doing what and who is ultimately responsible for the multitude of outcomes that happen with diabetes? So if we go to the next slide, I think that really highlights, I think, the challenges to patient attribution. Historically, we've thought about major challenges being the fact that many patients don't have a designated primary care clinician, even if we ask them. But patients are also obtaining care from multiple physicians and multiple advanced practice providers across multiple networks who use multiple different electronic health records. There's variation in the quality and access to data sources that define patients' interactions with all these aspects of the healthcare system. So if we try to measure health outcomes rather than process or structure measures, which are much more easily linked to a specific clinician or group or organization, that becomes more challenging. So as a result, there really is no gold standard for attribution. There have been multiple attribution models developed, and they all produce very different measurement results, which is why it's kind of helpful to think through the process of how attribution models are built and what they mean. So currently, there are over 170 different attribution models, either in use or proposed. And if you look at the next slide, it kind of demonstrates the wide heterogeneity of these attribution models. So and this is from 2016, so there's been even more models developed since then. But first, for the type of clinician that is attributed, for the different models, most go to any kind of attributable physician, which again isn't any, but it's either primary care or a certain number of specialties, which varies. Others attribute to facility, primary care physician, or they prefer primary care physician, but they do somebody else. They can attribute to a group, to a specialist, or it's actually just not clear. And then the other aspect is how many people patients can be attributed to. And the vast majority, 80% of attribution models really attribute to a single entity or a provider. So if we go to the next slide, I think that really highlights the challenges to identifying attribution in total cost of care models, because we really need to move beyond the dyadic patient primary care physician attribution. So first, even though it's obviously easier to attribute a patient to one entity, Medicare patients see a median of 2 primary care physicians and 5 specialists associated with 4 different provider organizations in a given year. So there's a lot of fragmentation and a lot of people being involved. So you have to recognize not only primary care, but different specialists. Then we know that, especially for chronic diseases, team-based care is associated with significantly improved health outcomes. So how do we account for advanced practice providers who are delivering care both in primary care and in specialty care? Collaborative practice agreements with pharmacists who manage an increasing share of the chronic diseases as part of a multidisciplinary care team. The same thing for other clinical support staff. And then clinician extenders who are almost never visible in claims data that are used for attribution, like community paramedics or nurses, social workers, mental health specialists, community health workers, and coaches. And then finally, there's non-visit care. So a lot that happens in primary care as well as in specialty care that never sees the light of a bill, even though that is likely going to be changing. But e-visits, portal messages, care coordination, and case management, all of those are resource-intensive touch points that improve patient health outcomes, and yet the responsibility for those is very hard to assign, because even if primary care physician is overseeing all of it, that will not be visible in any of the data sources that we're using to attribute patients. So next slide. Now, So attribution models ideally would identify accountable entities that are able to meaningfully affect the measured outcomes either directly or indirectly through collaboration with partners whom they can reliably influence. So when we think about specialist integration into primary care specifically, there's many ways that they can be integrated with different degrees of visibility in claims. You can have a standalone specialist separate from primary care. They could be within the same integrated healthcare system, which could be either closed, like a truly integrated healthcare delivery system, which manages all of the patient, like an ACO. It can be an open system where patients can come and go and can see people across multiple systems. It can be a regional referral practice where people kind of coalesce to see those specialists, or a destination referral practice where people come from all over the country or the world. Again, they're still responsible, but with very different utilization patterns. Now, when a specialist is co-located together with primary care, and that's actually my role as an endocrinologist inside of a primary care practice, there's different ways that we can be co-located as well. We can do consultative practice where we see patients occasionally like a regular specialist would. We're just located together. But we can also be overseeing and consulting on the patient's care electronically without ever seeing the patient. We can be co-managing with primary care providers, with seeing patients or not. So again, in this case, specialists are involved and responsible for patient health outcomes, but the way that it's presented in the data is very different. And not only does this change depending on the healthcare system that we're dealing with, it also changes across a patient's disease journey as their disease becomes more or less complex, or they experience exacerbations of their illness. Different models of specialist utilization can be apparent. So next slide. And then as an added layer of complexity, we have to consider the role of physicians and advanced practice providers. APPs can practice completely independently, having their own panels, both in primary care and specialty care. Or they can be supporting the physician, where the physician conducts the first visit and then supervises the APPs. The physician and the APP are jointly responsible for the patient, but we only see evidence of one in claims. Or the physician conducts all visit, and that's what we see in claims, but the APP supports all non-visit care and education and coordination efforts, so they're still there, and that entity may provide a lot of care. We just don't see it all. So next slide. And like I mentioned before, that level of specialist engagement and how it's evidenced in claims and EHR data is not static. So as you think about any chronic health condition, it goes through phases. Early on, management of a chronic disease may fall entirely into primary care. As it becomes more complex, a specialist may engage in a consultative model, seeing the patient occasionally. Then it becomes advanced and dominant, and a specialist manages most of their disease. But other specialists are likely going to be involved too. Even in a disease like end-stage kidney disease, where we think about nephrologists kind of owning and being the primary care clinician for that patient, patients still have other health needs that nephrologists may not be equipped to handle, such as complex diabetes. So there's variable, and within this, there's variable levels of communication, coordination, and integration with primary care and other specialties. And then, at the other end of the journey, as the patient enters palliative care and potentially hospice, we kind of go back again to a sole overseeing clinician. So it changes through the patient's journey. So next slide. Now, because of this complexity, we may need to have different attribution models for different needs. One may be used to determine which patient is included in a program, such as an ACO. Another for quality measure, such as diabetes, heart failure, COPD, or surgical outcomes. So ultimately, the accountable unit needs to be responsible for the care that it has actionable control over. But at the same time, we need to be mindful of administrative burden and waste that can be incurred by implementing these different attribution models. So it becomes bit of a catch-22 and a double-edged sword where we have to balance practicality with accuracy and fairness. So next slide. So hopefully I kind of didn't instill too much, I think, fear and anxiety about attribution. But as we think through all of these complexities, I think we all start thinking, well, how do we even identify these patients, these accountable units? So we could ask the patient. I think ultimately that's a great way to do it, but often is not possible, and our patients often don't know who are all the people who are responsible for their care. So the most common ways to use claims data, and we can either do retrospective or prospective attribution, right? So with retrospective attribution, patients are identified at the end of the measurement year based on who was seen during that measurement year, so that it allows assignment based on how care was actually delivered. But at the same time, health systems and clinicians don't know who they are responsible for until they have actually cared for them. With prospective attribution, patients are attributed at the beginning of the measurement year based on who was seen the year before. So that removes the uncertainty, but creates concerns about gaming the system, providing differential levels of care based on attribution status. Patients may seek care from units who are different from the ones that they're attributed to, so that could lead to inadequate representation of the care provided. So most attribution models used now are retrospective attribution models, but there is increasing interest and uptake for prospective attribution. And I think it's important because about 2/3 of patients who are attributed to one unit in 1 year stay for the next. So these methods are perfect. We then think about, well, we're going to be measuring utilization, use or contact somehow, but over what time period? So usually we do either 1 or 2 years, again, depending on your disease and how frequent you expect the touch point to be. Then what are going to be your unit of comparisons? Are you going to be looking at touch points, so claims or visits, or is it going to be cost and spending? And those can create very different results. What kinds of eligible claims? In primary care, we often use well visit or routine visits, but that doesn't work for specialty care. What about non-evaluation and management codes? How will they be considered? And like we talked about, who are the eligible clinicians? How many can be considered for exclusivity? Is there a minimum threshold for someone to even be considered to be counted? And how do we assign? Do we use plurality of visits or costs? Or do we use a majority? And all the existing different attribution methods basically take a different permutation of a way of identifying different accountable units. So next slide. So can we go to the next slide? Almost done. Okay. So once we identify those groups, we assign either single or shared responsibilities. So for our purposes here, we'll look on the shared responsibility to multiple clinicians or systems. And we can use, so using attribution rules for either one touch or requiring multiple visits, we assign responsibility to primary care clinician and disease concordance specialists for all of the patient's diseases based on eligible claims. And then you also, using the same attribution methods, assign patients to a system or to a team, depending on which measure you're talking about. So next slide. One idea that has been proposed and used really in other industries, but not in healthcare, that I think could be an interesting solution is to use weighted multi-attribution models where patients are attributed to all clinicians involved in their care based on predetermined weights, as long as we have a single kind of gold standard and fair model that everybody agrees on to figure out those weights. But those are currently used a lot for, MBA or internet marketing and ads to figure out, who is responsible. And we can use something like that in healthcare, but again, recognizing the need for standardization. So next slide. So kind of conclude with some final thoughts on attribution that you see here. And I think there's a lot, even though, so attribution I think is very important for all of these models, but there's a lot of uncertainty about how to do it with advantages and disadvantages of pretty much every decision point along the way. And it's important for whatever attribution models are developed, for them to first be tested, verified, and reviewed across very different types of delivery systems and care models to make sure that they yield the outcomes that we want them to yield, that are fair and equitable and don't disadvantage any type of organization or patient population. And ultimately, I think as we think of total cost of care models, prioritizing measures that are ascertained at the care team or health system level rather than individual clinician level, because that really will recognize and acknowledge team-based care as well as the complexity of managing patients with multiple chronic conditions. So thank you
so much, Rozalina. It was very thought-provoking. Next, we're going to go to Ms. Lily Brolstein, who is the Executive Officer at B Collaborative. Go ahead, Lily.
Thank you so much, and thank you for having me today. I'm delighted to be here and participate in this discussion. I've spent the last 10 years really hanging around with specialists, building episodes of care and other models, so I will share with you today some of my experiences around how to engage specialists in these models. And just sort of to start out, the goals really I think about from ACA was to create accountability related to quality, patient experience, and cost of care. And I think what we have today across the country are very well established, mostly primary care attributed ACOs. There's a very small percentage of specialists that are engaged in specialty care models alone, and certainly with the ACOs as well. As we kind of built these models, they were built kind of independently, right? So we built PCMH models for primary care. We built ACOs ostensibly for integrated delivery of care, although I think they really focus still today on primary care. And we built episodes of care or bundled payments for specialty care. So we kind of moved from the fee-for-service unit silos to kind of more collaborative models, but still silos, right? So we have primary care and we have specialty care living really side by side. So from my view, I see that we're on a glide path to getting to those goals of creating really comprehensive, collaborative, fully accountable care. And we now really need to talk about, and very grateful to be here to do that, about how do we do that integration and how do we actually engage specialists in these models. Next slide, please. So the number one thing that I really think about a lot is the perception of the docs is the reality that we absolutely have to address. And the reality is specialists are afraid and they're concerned. They don't trust payers, whether it's CMS or commercial payers. They're afraid they're going to lose their ability to make clinical decisions for their patients, and they're afraid to take on risk because they've never yet seen the longitudinal view of the patient. They don't necessarily know what's happening to the patient or what somebody else may be doing for that patient that may have an impact on what they do. They're afraid they're going to lose money. Unlike primary care docs, there's typically not anything up front for specialists, and they almost immediately begin to lose money when they come into these models. They're afraid they're going to lose control of their practices. They're going to be told to practice cookbook medicine, and they're afraid that there are going to be increased administrative burdens and time required if they come into these models. Next slide, please. So if perception is a reality we have to address, we have to actually be thoughtful about the language we use as well, because the language we use drives many of those perceptions. And I just put a few things down here, like presenting to a specialist that we've built a model for you is not really something doctors anybody really wants to hear, right? They want to, it reduces their trust. It implies some level of control and sort of creates more discord. Anything that is deemed mandatory implies a power imbalance, which I think is really counterintuitive to what these models and the work that we're all doing is about. Bundled payments, I do work in specialty care and in episodes of care, and this happens to be a phrase I don't like. I don't use it. I think when docs hear bundled payments, the only thing they hear is money, and it kind of reinforces their perception that payers are only concerned about the money and not really about the quality of the care. And here I went out on a limb, too, to say even value-based care, I think we need to be thoughtful about using that term and how we use it. I I think it has some connotations that you're shopping in the bargain basement, and nobody really wants to be engaged in that, right? Next slide, please. So this is so simple, I think, in terms of how to think about engaging them. But in my experience, it really works very well. So instead of inviting physicians in to share with them what you have built as a payer or any other group, invite them in to build it with you, right? They have expertise that can be leveraged and should be leveraged. Payers' expertise, no disrespect at all intended, is not in the clinical, the clinical to-dos, if you will, or the clinical care pathways. And so invite them in to build it with you and keep them with you through every stage of the build. So collaborate with them as partners in designing the model, what will actually work, in reviewing the data. They haven't seen the data before. They don't know where the variations in care and costs of care are until they actually see it. They allow them to help define the metrics. They know from a clinical perspective what are the outcomes that are the best, and get the patient's perspective as well. And then keep them in as you continue to review it and refine the models. I think it is really important, and I think François spoke to this as well, recognizing and respecting all of the stakeholders and leveraging the expertise of them. Partnership, really nothing, don't have anything built without the engagement of the other. And, a lot of what I spend my time talking to groups about these days is that these models need to be clinically meaningful, and they also need to be able to be administered by a payer. So we need everybody thinking about this. We don't need payers who are only thinking about creating predictable costs, critical importance, but we need them also thinking about clinically meaningful models, and we need physicians thinking about clinically meaningful models that really make the most effective and efficient use of very limited resources. And then, of course, there's the, keep it simple. If it can't be easily explained or described, to a doc or by a doc, it's not going to be they're not going to be successful within it. Next slide, please. So I have a few sort of considerations for how to kind of incentivize and engage specialists in some of these models. The first thing is, respect that each specialty is unique. There's primary care, and then there's specialty care, but specialty care isn't a thing. Specialty care is a whole lot of things. It's cardiology, it's orthopedics, it's oncology, and, so many others. And so each of them is unique. Each of them have unique requirements. So if you have one specialist, you don't have specialty care covered, meaning if you have one specialist engaged. The disease treatment pathways, whether it's acute, chronic, or procedural, really have an impact and need to be considered individually. I think the docs who and the providers who are caring for people with chronic conditions, and Mark and François both talked about this as well, and actually Rozalina, often doctors who care for individuals with chronic conditions are the principal point of contact for that individual. They may not even be seeing a primary care doc. And so I think we need to figure out how to address that, right? That care is not typically episodic in nature. And if it is, like in oncology, it's long, right? It's not a short 120-day procedural kind of episode. When docs caring for patients who have long care needs in the specialty space, there's not money up front that helps support their ability to implement tools and make changes in their in the way they care for their patients. And they often have to wait a very, very, very long time to see the outcomes and then get paid. It's a big disincentivizer, if that is actually a word. I would also say, inviting specialists to be represented in the leadership on the ACO governance teams, the boards and committees is really important. I heard some of the comments earlier today that sounded a bit to me like the primary care docs, are at the helm and are going to be telling the specialists what to do and whether they can or can't do something for the patient. I think that is not a way to engage specialists, and it's really not a way to get to the most consistently good, optimal outcomes. I think we need them engaged in leadership. We need them engaged in some of the decision making, and they don't want to be led by primary care docs. Partnering with them as partners, yes, but not directed by them. Next slide, please. Thank you. So again, creating financial models that don't immediately put specialists at a loss. So in primary care, there's money up front. There's an understanding in primary care, I think, that you need to spend money in the short term to get to better long-term outcomes, right? Bring people in for their flu shots and their mammos and all the preventative care. Typically, that's not considered in specialty care. And the minute a doc steps in, they're often, again, start to lose revenue. So I think building models that have some financial, not even incentive, but support for the docs to be able to make these changes is really important. I think staying focused on the long-term improvements in care rather than only on the immediate ROI is really important also, as I think we think about in primary care. I would talk to them about what they perceive they need. I also heard a lot of discussion today about how specialists can provide information to primaries, but I would argue that the specialists need a lot of information from the primaries, who often have the most information about the patient that can actually have an impact on the work that the specialist does. This last one, I should have put it bigger and bolder because I find it so important, and I have had lots of discussions around this over the years, but specialists don't have enough experience here, and they are really afraid. And I understand the need to get to predictable costs. That is number one priority for payers. But I think bringing providers in no or low risk, minimal risk models to begin, to allow them sort of to be in a live learning lab, if you will, to study the data, see that longitudinal view, see where the variations in care and cost of care are. They will then get to a place where they begin to understand perhaps, their school chum or the person they met at church, where they're referring might really not be the best place for them to make their referrals. And without that data, they don't know that, right? And we heard talk earlier too about how difficult it is to change those patterns. But I think if primaries and specialists are engaged together, see the same data, and are focused on the same goals, you'll begin to see those patterns change. I've never presented data to a provider and not had them say, "Oh, I didn't realize that's what was happening. We can address that." So again, sharing the longitudinal data to assess the opportunities, really, really important. And then I would say sort of cultivating and nurturing the relationships are so important in a way that we don't see in fee-for-service in any respect, right? We typically have units of care, and they're paid in units of cost or unit fees. In these value models, they rely on ongoing communication and collaboration to review, refine the models, make tweaks, see what's working, what's not working. And so a regular cadence of collaborative review of the challenges and the successes is really important. And I know this sounds kind of shocking, but I think it is really important that CMS and all the other payers, by the way, I spent 20 plus years on the payer side, and so I saw this live for myself. You can become the trusted advisors of providers, which is just amazing, right? To be really working hand in hand, as long as you are open to it and you are willing to share data and talk on a regular and ongoing basis. Next slide, please. Oh, do I have another one? Yeah. So this is just really in summary. I do think it's the spirit of collaboration that will get us closer to creating comprehensive accountability for care quality, for patient experience and cost of care. And again, I think if I could reiterate the most important points I think of that I think in this space, I think inviting the doctors in to build with you, leveraging the expertise that they have, have appropriate representation in the leadership of these integrated models. We need to build, I think we all want to, and we need to build meaningful medical neighborhoods. And that isn't just primary care. That's really an integration with the specialists. And I think, by doing that, you begin to see not just engagement by the specialists, but you see enthusiastic engagement, which also leads to ongoing innovation and engagement that leads to improved outcomes. So I thank you so much for the time and the opportunity to speak today.
Thank you so much, Lily. That's such an interesting way to tie together all four of these presentations. Now we're going to move into the section with questions from our committee members. If you could tip up your name tag like this if you have a question. And what I'd like to suggest, we have from now until 4:10, and there's a lot of rich content here. If you can think about a succinct way to ask your question, and then choose two of the panelists that you would like to respond so we can get to as many questions as possible with this esteemed panel. So who has a question for our panel members? Angelo.
Thank you. So yeah, great presentations. And I guess my question for more clarity on my part is to Mark and François. So as I think about those subcap models as you described, help clarify for me how you identify the population for the particular specialist. And so is it all patients within that category of disease, or is it risk stratified in some way to hit a threshold that gets attributed to that physician? And if that patient has multiple comorbid conditions, then how you decide which specialist that subcap might go to? Thank you.
François, I might defer for you to go first, despite your comments earlier. I think you've got more certainly technical experience here. Maybe I can add a few just high-level comments.
I'm trying to get myself off mute.
There you go.
Okay, I was trying to get myself off mute. Sorry about that. Yes, so a few points. First, it's not necessarily a pure subcap, but I guess it's not a bad idea to think about it in a simple way. Number one, from that perspective, I do think, building on Lily's comments, this isn't just about carving out patients and putting them into the hands of specialty care providers, more than having a population of patients, some of which are going to require specialty care, some of which are going to require primary care, and a collaboration between both. And the patients, in fact, can be shared and should be shared between the primary and the specialty care providers based on their severity at any point in time. If you use the CKD model as kind of a base for thinking about this, as you know, there is a clear delineation. It's when you reach a certain stage of CKD that you become attributable to the nephrology practices that are participating in that program. Rozalina spent a fair amount of time talking about the challenges associated with attribution, and there are challenges, but I think there are also ways of working underneath a population health umbrella to have the delineation between when the patients start falling under the responsibility of the specialty care providers, and when it's better for them to continue to be cared for by the primary care physicians. And yes, you're right that many Medicare beneficiaries have multiple conditions at the same time, and the costs associated to those can be attributed, again, to different specialty care providers. So it is math, and there are ways and mechanisms to parse out those dollars to the extent that it should be done and it makes sense. because if the patient again has severe IBD, in addition to having advanced cardiac condition like heart failure, then they're going to be co-managed by both specialty care providers and by the primary care physician. So, some of this is we try to overcomplexify it sometimes, but if you pull back and you think, well, in an integrated system, it kind of works. And so how do we replicate the mechanisms from a financial standpoint and attribution standpoint so that it works just as well when everyone doesn't belong to the same legal organization?
Yeah, I would just add, I agree with everything François said, and just maybe a little bit higher level here. Rozalina did a great job of outlining just how hard this is, given the complexities of care. And I would say that's especially true if there's not an overall accountable provider or entity that can help put these pieces together and make sure they make sense for that particular patient. CMS has worked out a way to do this for the acute episodes. I think that's one reason we have acute episodes, and I'll say it, Lily, bundle, that's what they're called, because it's a relatively short period of time after a major procedure, and you can kind of be confident in attributing that to a particular specialist or group for that episode. It's harder for the longitudinal conditions, and that's why we've focused on sort of two main points. One is if you are in a hospital-based ACO, that includes increasingly attributed primary care providers or associated primary care providers and specialists, and there will be acute episode payments within that. There's just no easy way for that hospital-based ACO to shift resources and support for those specialists out of just doing those procedures and into more of a longitudinal model. So having attribution to a specialty provider for the condition based on, as François said, some minimum threshold set of conditions. For example, he gave one example for degenerative joint disease, which everybody has. It could be referral to an orthopedist or orthopedic condition management group with a certain minimum level of findings or workup or something like that. Well, that's hard to make work as a standalone because everybody's got that age has some level of degenerative joint disease. But if it's within a hospital-led ACO, well, they've got some reasons to pay attention to how many patients are getting referred to specialty, hopefully longitudinal care, not just orthopedists who only have a reimbursement path for the procedures. Conversely, for the primary care ACOs, we view that as being a template that they can use to facilitate their interactions, much as Lily said. Let's start with providing data at the condition level on how different specialty groups are doing. And again, you can start with, have to start somewhere with a reasonable measure of when a chronic episode should start and what services should be included. We're only going to make those better if we start trying out these models and get more experience over time. There are a number out there that can be used, and they need to keep getting refined. We think we ought to start with some of the most common conditions where there are these big opportunities potentially for supporting better longitudinal care model collaboration. And from the primary care group standpoint, if they're only implementing these models with specialty groups or longitudinal specialty care providers that fit with their priorities, they can have some control over when that attribution occurs. They can keep trying to do all the care themselves, if they really think they can, there's not enough savings to go around and they can do all of this. I don't think, as François said earlier, that's very feasible, but at least they'll have a clear path and some initial data on where they ought to go, and there'd be a clear path for the specialists who want to work. Maybe it's capitated, maybe it's just a more limited amount of risk sharing and scope of responsibility sharing, but at least you've got a framework with a range of options, clear options to start with, and some data to help encourage that kind of constructive longitudinal collaboration.
Got it. Thank you. That's very helpful.
Larry, please go next.
And this time I remembered to hit both buttons. Fantastic session. I love I love the application of science to the chaos we've been living in for the last 30, 40 years. And I don't know who is best to comment on what I'm going to say, but what I've come away with from this session is to no longer want to talk about primary care this, specialty care that, but rather to look upon this, what we should be doing as crafting a complex attribution model or a set of attribution rules to create sub-buckets of risk that are disease-specific, and then apply the right providers to take care of that. Because, in the GI space, some of my colleagues, all they do is colonoscopies for screening. So they're prevention doctors. Then there's others that love to be at the hospital in the acute phase and love to take care of the acutely ill patient. And there are those that love to be in the office and take care of the chronic care. They're all gastroenterologists. They're all specialists. They're providing different segments of the care that a patient with a disease takes. So maybe we need to turn this upside down a little bit in our terminology and say we're creating disease-specific attribution models so we can provide the right care to the right patient at the right time. Great session.
Did you want to ask any panelists to make any comment?
Should we start reversing how we're talking about this? Instead of talking about specialty models and primary care models, should we be talking about disease-based models?
So I'm happy to make a comment if I can just jump in. I think, Larry, to my view, it is really about sort of creating collaborative models, not primary versus specialty, but leveraging the expertise of each and every one of them to be able to build models that address the care of the community, right? So sort of that medical neighborhood concept, I think. In terms of turning it upside down on its head, at the risk of, really being out there, I think in some ways that is what we have to do. We have to sort of rethink the language that we use, and we have to rethink, what the builds look like. We don't build for, we build with, is sort of, I think, the model that will get the most engagement and create the most success.
Any of the other panelists like to comment? I see Mark shaking his head.
Oh, yeah, I agree.
All right, thank you. We'll move on to Jen. Please go ahead.
Thank you again to each of you. What a wonderful series of presentations. I want to go back to focus on one very small point. And Lily, you made the comment about anything mandatory implies a power imbalance and why that might not be palatable. But at our last session, we actually had a lot of conversation around should participation in value-based programs be mandatory. So I'm curious your thoughts on that idea with regards to specialty care, or I guess if we're going to reframe, disease-based care models for which specialists provide care. I think for Mark and François, this is for you, but I'd open up to anyone who has an opinion.
Well, I agree. Sorry, go ahead, François.
No, please.
No, I agree with Lily's point, but François, let me defer to you, and I'll pick up from there.
Yeah, look, I think what we have learned in the process of the past decade or so is that there are some models when they are fully baked in and where there is evidence around the effectiveness, they should be mandatory. I mean, in the document that Mark mentioned and prior ones that we've worked on, I think we're really clear about that we all think, there should be kind of mandatory 30-day, you want to call them bundles, you call them bundles, you want to call them some payments for acute and post-acute covering 30 days, and it should cover all DRGs and, just get on with life because it helps optimize post-acute care, and we kind of know it works. I think for the rest, it's really difficult to do mandatory unless you really know that something is effective. And the concern of jumping into, say, mandatory today in the scope of what the agency has really focused on, which are things like total joint replacement, or, if they want to do the equivalent in cardiology, let's say CABG or stents, is that, again, you're taking a piece of a slice, and taking just a slice is not the way to engage the specialty care providers, and you're treating at that point the procedure, but what about all the upstream work that should be the focus of these longitudinal care, these condition-based programs? And so, to Larry's point, I think if we do flip this and think of it individuals have conditions, these conditions need to be managed, they need to be managed collaboratively between primary specialty care providers, and the specialty care providers come in different forms and varieties, as Larry has mentioned. And before we start mandating a whole bunch of programs that will likely mostly be centered either around acute episodes or procedural episodes, let's start by testing out and working through what really matters is the longitudinal management of conditions.
And to get to the longitudinal management, just to build on François' comment, mandatories come up in a couple of ways in this session. One is, I referenced the CMS statement that they are considering, and they're not doing it, and they're not doing it right now, but considering moving to mandatory versions of these acute episode models. And I think that's a reflection of a real challenge that I hope PTAC can engage on with voluntary models. It's not that they can't improve care and they can't reduce the total cost of care delivery. It's that they can't do those things and save money for Medicare, or even break even for Medicare very easily, especially as you get into more fine definitions of episodes of care. So BPCIA, according to Medicare actuaries, and their numbers may not be exactly right, it's hard to know, but lost a lot of money in its early years because it was hard to set those benchmarks right. And then once you set the benchmarks, it was an opportunity for groups to understandably look at how they're doing now under current financial performance and the current payments versus how they do under the alternative model. And if it didn't look good, good reason not to participate. If it did look good, it's a great reason to participate. But again, and it'll help drive the changes in care that you want, but it leads to more, not less spending for Medicare. And that's happened in a lot of the voluntary specialty models. When we adopted other major payment reforms that I think have generally been regarded as successful, at least incremental steps forward, they've A, generally moved away from fee-for-service, and B, generally haven't been voluntary. So think about DRG-based payments for hospitals and all the episode payments under the traditional Medicare system that are now in place for essentially all types of facility-based care and even home-based care. So I think it's going to be hard to get to a truly person-centered, longitudinal care-focused system if we are only forever planning on doing voluntary approaches, at least doing it in a way that's at all fiscally sustainable for the country. So if we are moving to mandatory, we need to do it carefully and thoughtfully. What CMS laid out, for example, for the future of the BPCI is they're aiming to provide data on all specialty providers and do it for maybe a couple of years to help people get a sense of where they are, help set the benchmarks and other features of the program right before moving to something mandatory. We talked about mandatory in one other context in our presentation, which was within the hospital-based ACO models. Remember, there it's a little bit different. Those hospitals are already accountable for the total cost of care for the patients that are attributed to them. They're just a bit hamstrung in implementing these specialized care longitudinal models in that they're being paid, their specialists are being paid on a DRG plus, episode basis, which means if you look at the financial arrangements in these hospitals, they've got primary care providers that are trying to keep at least some, chronic patients out of the hospital, but for the specialists to sustain their practices, they've got to do the procedures. That's where most of the money is. So a mandatory shift away from that, it's still all money that the hospital gets or is accountable for, but it provides a stronger push in the direction of moving towards these longitudinal care models. And we do think that, moving beyond that at some point may be worth going to, just like we have a mandatory, fee-for-service payment system now, someday we may get to one for specialized care, but there's a lot to learn on the way. I just think it's probably not realistic to think we can only be voluntary and really move away from, very fragmented fee-for-service, procedure-oriented care.
May I make a quick comment on this?
Please do.
Thank you. So I just want to clarify, I work very hard every day to help progress the move from fee-for-service to value. I think it is the right thing to do. I think the language we use to engage or talk about it is so important. So to Mark's point that he just made, we don't refer to fee-for-service as mandatory. It is just the standard model of payment. And so talking about voluntary and mandatory, it's the language, I think, right? Like maybe the folks who start out in what's called mandatory now, maybe they're the beta testers, right? Or some other language. And then ultimately the value-based models, whether they're called that or something else, becomes the standard model of payment. But the language we use, from my experience and in my view, makes a huge difference in how and if you're able to get doctors and others actually to engage in the models. Nobody wants to be told you're going to be mandated to do this. Rather, we're evolving perhaps to another model of payment, and we have initial beta testers or whatever we call them. So I just want to make sure that's clear. It's not that I don't think the move to value is critically important. I do. I think if we want to get there, though, we have to be really considerate about the language that we use.
Committee members, any additional comments, questions? I'm going to throw one out then. So this may sound like a tangent, but I think a lot about longitudinal management and how important that is, the relationship, the trust, and how strongly that type of approach builds the possibility for anticipatory management, preventing crisis, and really holistically addressing clients' needs. So I'm curious, in light of that, how are you thinking in these payment models about the integration of community partners, health-related social needs, and some of the people who naturally have longitudinal relationship with patients and may actually have the most contact with the client? Just open that up to any of the panel members to comment on.
Maybe I can start with a few comments. I completely agree with you, and I think just about everybody on the panel who has really put out some good ideas and encouraged the path forward to more longitudinal, and to support more longitudinal engagement of specialists in whole person care. I think you've seen a consistent theme around that. I just would emphasize that if we really want, I think there's now a lot of experience, if we really want to address these social factors and reaching patients where they are, establishing trust, et cetera, it's very hard to do that under fee-for-service. I mean, we're making very incremental changes in Medicare in that direction. There's some care management fees mainly only for primary care providers, a little for behavioral health now, and those are hard to get added to fee for service because they look like, if they're not coordinated, they're concerned they're going to tend to add to cost. There's a little bit of payment in fee for service for maybe for a pathway for food or some preventive community services like the diabetes prevention program, but even there, those are quite limited, not very comprehensive. In contrast, in organizations and Medicare, Medicaid especially, where we have people with a lot of underlying needs and complications, lower incomes that are getting in the way of causing health problems that are preventable. We've seen a lot of examples now of ACOs and other programs, including programs involving specialists, move to addressing nutrition needs, addressing transportation needs, building care teams that rely on traditionally unreimbursed and Medicare providers, at least not directly reimbursed. So the more we can adopt these models, and especially if we can reinforce the importance of engaging specialized care providers in giving patients the best longitudinal experience, and they can be very helpful. It's not their only job, but they can be very helpful for patients that have that strong specialty care relationship and identifying early intervention. Kevin Bozick has a great program at Dell in Austin that has sort of essentially eliminated the waiting list for uninsured Austinites, and there are, unfortunately too many of them, for getting access to joint procedures, not by doing a ton more joint procedures, but by setting up these care models that get to an early triage, early intervention, addressing behavioral health needs, supporting, community-based nutrition interventions, exercise interventions, things like that. They're just so much more effective for people with specialized conditions.
I would add a comment too and say, as I think about these models and the comprehensive care, so much of what happens these days is about what the health plans have defined as covered benefits. And we know that what impacts a patient's ability to get to the best outcome and physician's ability has a lot to do with things that are not traditionally covered benefits. So, for example, in the commercial world, it's very unlikely that if a patient can't get to the doctor, that a plan would pay for an Uber or a Lyft, right? When we move into value-based models and we contemplate patients' outcomes, we know that getting a patient to the doctor has a pretty big impact on their outcomes. So we begin to see the incorporation of transportation, food, all sorts of ancillary services, people going into the home to see does the patient actually have a refrigerator to keep their meds cold, things like that. And I think as we move into value-based care and we begin to create models that pay for outcomes and allow the clinicians and the care providers to assess what is it that really has the biggest impact on the individual, and let them spend the money the way it makes sense, right? Once they move into risk-based models, I think really begins to get at kind of, I wouldn't say all, but most of the things that impact a patient's health that include and are outside of traditionally covered benefits.
Yeah, Rozalina, I see you shaking your head. Would you like to go next?
Yeah, I definitely agree. Especially for, chronic diseases and multimorbidity, social determinants of health and factors that are outside the healthcare system are really dominant, and they can't be addressed, I think, without upfront investment and recognizing the care that those community partners or non-clinical partners deliver, which is why I think finding ways for them to be present in claims, to be captured, and then for payment to be shared with them and assigned to those services, I think is really important. But to start, there is an upfront cost to starting those up and to creating the community clinical partnerships. So I think that would have to be a part of the total cost of care model that really recognizes the totality of the patient's needs. And, in Minnesota, Medicaid, for example, has been reimbursing for community paramedicine, and we've seen a lot of growth in that, but that's really unique. But I think we've seen how much even small financial investment in new models of care can make a big impact. So learning from experiences like that, I think, can be very helpful.
François, would you like to add anything? No, okay. We have exactly 5 minutes. Any last burning questions? Lindsay, please go ahead.
Thank you. I don't know if it'll do it justice for 5 minutes, but I think, in other industries, we think about how, we have consumer demand that drives us in certain directions. And it's been great hearing, I think, the conversation about, how we can value specialty care in some of these disease-based models. But I think one question I have is, once we build it, once we figure out attribution, how do we, outside of it being mandatory, what incentives can we create for patients to want to go down that path? And I guess what incentives do we think patients have, or what incentives can ACOs or specialists create to use those high value sites of service or specialists that have been baked in? I think the missing piece for the consumer, in this case, the patient, to understand why a model like this is beneficial feels a bit missing. And I worry about a mismatch in patients placing other things at higher value, such as it's a mile from my house, or I know them from my church, as opposed to being able to understand that there's a value to it. So feels like a bit of a tangential conversation, but just curious how we think about, once we've designed this system, what incentives could we create in a payment model that also takes into effect how does the patient benefit from it outside of just getting a higher quality care in the end?
Panelists who would like to respond?
Oh, well, higher quality care is an important benefit, but I would say that the time to build in consumers or patients isn't, once the model is developed, but as you're aiming, what should we be aiming for? I think the recent CMS specialty care strategy that really emphasizes the whole patient journey, and as Lauren was just talking about, that's what people care about. I mean, the best surgery is the one they don't have to have. The best hospital admission is the one they avoid. The best complication is the one that doesn't happen. And right now, it's very hard for patients, or for that matter, their doctors, to be informed about that. And we heard earlier about the lack of data at key times when patients are making major decisions. Which primary care doctor do I use? Well, we've made some progress on that, but where do I go for my joint disease care, for my my heart failure, my diabetes? We don't have very good data on that. And it's not for lack of effort. There's been all kinds of transparency legislation, some that CMS is trying to implement now. But I do think as an initial step, the CMS idea of having what they're calling shadow bundles, and they should get rid of the bundle term from the standpoint as Lily was describing, but and shadow also sounds a little bit spooky, but what those are really about is level of information, the level of an episode of care, an experience of care for a condition or for a hospitalization or for an elective procedure that rolls up the total cost, maybe rolls up out-of-pocket costs, includes some important measures that people might care about, like complication rates and readmissions. If you go to condition-based versions of that, as we proposed as a starter in this direction for major conditions, you can also start really getting at what matters to patients, which for chronic diseases is again, avoiding the hospitalizations more so than having fewer hospitalizations in them, and getting a better overall experience with their condition. So if you've got condition level episodes where you're providing transparency, it becomes easier to produce measures like, you could start with net promoter scores, but for all of these conditions, there is generally a patient-reported outcome or set of outcomes that matters. For Alzheimer's patients, it's, am I independent? How much independence do I have? Do I have to rely on a nursing home or other kinds of assistance? For people with joint disease, it's not how good was my surgery, but what's my functional status? For people with back pain, what kind of pain do I have? And the last thing I'd add to that is you can also add in benefit design changes where going to the provider systems that are best at the condition or person level should be the ones that cost less for the person.
Any other panelists like to comment?
Just the whole thrust of what we're I think we talked about, all four of us, is that collaboration between primary and specialty care. And so to your point today, a lot of the decisions end up by being influenced by other factors. And it's in large part because you still have these siloed views of care. And until we change both the financial and other interactions between the primary and the specialty care providers, it's not likely to change, and therefore the influencing factors of those decisions aren't likely to change. But the information that Mark mentioned is critical to help create the evidence base around which of the specialty care providers are effectively going to manage, if I'm the primary care physician, effectively going to manage my patients the best. But beyond that, I'm also working collaboratively with them on accountability for financial and clinical outcomes. So it's not just a collegial relationship or someone that I, go play golf with, but it is literally a business partner, a care collaboration partner, someone with whom I share patients underneath the umbrella of a broader accountable system.
On behalf of the committee and our audience, I want to thank each one of you, Lily, François, Mark, Rozalina, for the generosity of your time and your tremendous expertise. This was incredibly engaging, and we really appreciate all of your insights. At this time, we're going to have a short 10-minute break. We'll be returning at 4:20 Eastern. At that time, we'll reflect on the day and discuss some potential comments for the report to the Secretary. You're welcome to stay on for the rest of the meeting today. Thank you all so much.
Welcome back. We've had a great day today. A lot of subject matter experts who have shared their expertise and insight with us. It's been a very productive day today with a lot of robust discussion. As you know, PTAC will issue a report to the Secretary of HHS that will describe our key findings from this public meeting on improving care delivery and integrating specialty care and population-based models. We now have some time for the committee to reflect and discuss what we've learned and heard throughout the day. We will hear from more experts tomorrow, and at the end of the day tomorrow, we'll have more in-depth discussion about what we've heard over the 2 days, and we'll use that time to construct a report to the Secretary. So at this time, I just want the committee to look at the potential topics for deliberation. If there's any things that we feel like we need to discuss today, then we've got a few minutes to discuss those while they're fresh on our mind. Otherwise, we can save topics and talk about them once we've heard all the experts tomorrow afternoon. So I'll open it up to the committee for comments.
So, Angelo, I'm not going to be here tomorrow. So one of the things that struck me today was I was really fascinated by the e-consult conversation, because if you're really trying to drive integration with specialty and primary care and to leverage technology and to take some of the learnings we got out of COVID, I would think that either, delivery system, hospital-based ACOs, or freestanding primary care ACOs would really try and leverage those two technologies. And, a couple of the companies that she didn't name I'm familiar with, that they, especially in the Medicaid space, they really showed considerable savings and increased patient outcomes with increased utilization of e-consults. Especially when the health system or the specialists were created by the risk-bearing entity itself, as opposed to going out to third-party specialists across the country who may sound great, but had no connection to the local community. So I just, would like us, others, to think about, what are the ways that, and I know telemedicine is back on the table, how long it's going to be covered at what level for going forward, as a way that we should really consider leveraging that virtual visits as well as e-consults going forward. So that's my comment for today, and I apologize for not being able to be here tomorrow.
No problem. Thank you for those comments. Well noted. So Any other committee members have comments for today? Jen?
Thank you. I'll make these comments now rather than holding them for tomorrow. There were many takeaways from today, but I have 10 that I think are worth identifying that we could consider ultimately in our final report to the Secretary about best practices or key themes or ideas. The first is that there needs to be some consideration for the upfront costs and spend that saves money on the back end. So when we heard our first presentation, there was some note to other programs, which I believe were interpreted to be meaningful use infrastructure payments, and how important that was ultimately to building infrastructure that was ultimately a process measure for the outcome measure of delivering high quality, high value care. The second I heard was around the need for continuation or expansion of technology-enabled care, i.e. telehealth, and how critical that is for care delivery. And then ultimately, there needs to be some consideration to make it more attractive from a payment perspective. Next was that practice transformation. Yes, it's expensive, but again, can save money in the end. But it takes time to build and reorganize, and it requires flexibility. And so really a focus should be on long-term improvements without focusing on the immediate ROI if nationally we want to achieve ultimately our goals. We also heard endorsement from our experts around a recommendation of a multi-payer strategy so that there is a disproportionate number or majority of patients in a panel who are engaged in value-based programs to make it attractive for participation, i.e. an incentive. I also heard we had, as a PCDT team, wondered about should there be carve-outs, and I think we heard from our experts that there should be carving in as opposed to carving out. We also heard that price and data transparency would be helpful to surface information about where opportunity exists and where to create value, and that timely insights were critical or are critical. Number 8, that prospective, we heard in our most recent discussion, a recommendation around prospective attribution being a best practice and why that would be valuable. And then considering letting patients decide the attribution with affirmation by a provider about that relationship. And then also considering a weighted attribution model so that it's not just based on one relationship, which doesn't typically reflect actual care delivery. Next, that voluntary participation in programs, i.e. a beta test. What I heard is that this can't last forever, and if that we are ultimately to get to meaningful change, we need to evolve to a maybe novel payment program, but one, call it mandatory or call it the standard, but either way that we need to pivot from testing ultimately to something that is sustainable. And then last, I heard that we really need to be focusing on prospective longitudinal whole person care when we're thinking not only about our care models, but payment models. Thank you.
Those are great comments and great list, Josh.
Yeah, a day with lots of interesting and thought-provoking, I think, comments. My overall kind of takeaway from today was really that, we can't think about specialists as like a yes, no, all or nothing type of thing. Heard a lot of real nuance and feathering of kind of detail in there. So acute episodes or procedure-based clinicians versus those who might manage longitudinal or acute episodes, et cetera. We saw many figures. My head's still spinning about how they all come together, about how these all fit together. But that complexity, I think, was really helpful. And I think what that means for me, though, is that in some ways, we are a committee focused on the technical aspects of payment models. And so when I try to land that and how these models work, I do think the arithmetic is a little more complicated than that. I think in part because subspecialists have different scopes of practice, right, that we need to acknowledge. It's not that all of them just do a procedure or just do acute episodes or just do longitudinal outpatient care. I also worry about a bit of a, I don't know, this is not the intent, but I just want to say for the record that I don't think what we want is a subtractive strategy where we say, well, once we take this condition and that condition out, primary care is what's left of that. And I don't think that squares with clinical experience or intuition. And so the last thing is really like, Larry's comment about this idea of integrating and thinking about, well, who are the clinicians and the groups we need to bring together for that? And I think if we really want to grapple with it, it also means introducing, when we think about integrating subspecialists, it means how do we think about panel management, population health measures, all the things. We heard a little bit of that today, but I think many primary care clinicians, that's what we do. And I think bringing that kind of awareness, skill set, capacity across different clinician types, I think is really important also. So.
Perfect. Thank you, Josh. I think Chinny has a question.
Sorry, I'm falling into Larry's double click thing. So, from a comment perspective, I've got, similar to Jen, about 5 things that struck me from today that I thought was really insightful. First, I love the idea of it's come up a couple times, the shadow bundle and being able to provide that data to ACOs so you can actually figure out sort of the arbitrage behind care mechanisms and episodes between specialists. And then that leads into something that Larry spoke to in Jen's slide presentation is the variability in disease episodes. And I think we don't have a methodology to account for that variability. And I think adding, landing the plane on financial incentives attributed to some level of that variability, I think is really important. Mandatory versus optional came up a couple times, and sort of leading into co-attribution. We think of attribution as primary care attribution, and in really getting to a more co-attribution sort of thought process. And the thing that I loved Mark's slide on, sort of that longitudinal episode and the way that it is initiated by a diagnosis and it takes through the life cycle, and how do we sort of cost that out and have benchmarks with that cost. But I think the thing that I'm sort of still struggling with, and I feel like is a really big part of value-based care and a really big part of integration or anything to do in total cost of care is health equity. And I don't think that didn't make its way. That's the one thing that didn't make its way into a lot of the sort of thought processes today. And I would have liked to have probably seen more of that. I know that it was brought up as measuring it, studying it, but not really as a part of the solution and how you solution around it. And so those are some of the thoughts I had.
Thank you, Chinny. Lindsay?
Yeah, thank you. Hard to go after those lists. I think 2 comments, and maybe it's a little bit going off of what Jay was struck by with the e-consults. And I think I heard themes in all 3 of the discussions around the need for care coordination, data wrangling, I think it was called by one panelist, collaboration, integration. And I think all of them talked about the value of it for patients, even by the perception of specialists finding value in that sense of relationship. But I'm not sure there's great definitions of what that looks like. What does it take? Who does it? And quantifying the time it takes. And I think it ties in for me a bit with the e-consults, and that the valuation is for the specialist to do the e-consult. But what does it take for the primary care team to submit the consult, digest the results, communicate it to the patient, and how is that quantified? Now, it's valued in savings downstream, but in a system where time is still limited, if you're layering it on to existing work and not valuing it as a separate thing, how do we encourage that type of behavior? And I'm not sure there's great models for how you quantify it outside of a CPT code. I'm not suggesting that, but just how do we quantify the work and what does it look like to do good care coordination, I think still lacks some definition. I think the other theme maybe off of that struck me was just around this theme around the intangible relationship, and outside of payment, how do you put value on a good relationship between specialty care and primary care? It's a little bit of that quadruple or quintuple aim around joy in practice. I mean, I think this is in its purest form what many specialists and primary care docs alike would love, to be able to pick up the phone, talk about a patient, get quick resolution, reduce friction. And how do you value that, and how do you measure that, and would that get us somewhere as well outside of just payment? So I think those were themes that struck me that seemed to tie into many of the different panels today.
Great comments. Jim?
Yeah, I wanted to piggyback on I had two comments. One was on the relationship management in the broadest sense of the word between all the stakeholders. Seemed to kind of jump off the page that that in our efforts to improve quality, achieve the triple aim, we may have an unintended consequence of disintermediating people in their relationships, their longitudinal relationships. And it could be that what we may want to set up pretty high, that one of our priorities is that we do the opposite. We reduce the friction and the dissatisfaction of the practice of medicine. The profession itself has a high level of, I would bet, not recommending to their children to go into medicine. So how do we have some degree of responsibility and accountability as a committee to suggest to the secretary that one of the things that we really want to try to accomplish is to help make sure that there's an active workforce in the future that's in the healthcare segment, and that physicians, nurses, and others that aren't feeling disintermediated all the time in these kind of long relationships. The second comment I would make would be, I heard really a great comment that I think bears attention, which is a focus on data analytics using new technology, which is obviously AI, machine learning, that's very sensitive to bias, right? That's sensitive to skewing data to those less representative groups, those people that are marginalized and find themselves kind of on the wrong end of the healthcare quality and, oftentimes avoidable morbidity and mortality. And placing that at the highest level we can for the secretary to say that, hey, that we really know that one of the real challenges with the economics, the big economics of our system, has to do with a historical arc that has disintermediated people in certain populations based on the way on their own personal characteristics, that just has a huge anchoring effect on performance, on cost and quality performance. But that's generations in the making that can't be unpacked in this generation by a few schematic things that we do here. And so that we see ourselves on a kind of a long-term journey and see if we can shift as this discussion away from this kind of fear base that we're going to go bankrupt, the system's going to go bankrupt, and we don't find the silver bullet now. When in reality, the thing that's creating the threat of bankruptcy is kind of generational misbehavior as a society at large toward people of color and immigrants. And that's just, we can't really fix that with new payment schemes. We have to actually do a holistic transformation. Well, we, the medical profession, can be an agent of that. We can be the voice of that, but we can't do that without proper policy support in order to accomplish that. So that's kind of the comment I would make around the two things I felt were that wasn't already stated. Let's put it that way. I'm trying to color in between the lines.
Yeah, great comments from everybody. And it was a good session today. I heard a lot of recurring things that we've heard from a lot of other sessions that we've had. And, some of the things that stood out for me in terms of really trying to drive longitudinal care, which was a great discussion today, is one of the big things we're missing is still the ability to get adequate data, because it falls into the quality, the cost, the risk adjustment, everything that we're trying to accomplish. And then the other thing that really stood out for me today, just to add to the list that you all have already stated, is the administrative burden of the inbox of the primary care doc, and the fact that they really need a team around them. And right now we're relying on the doc to do most of the work. And somehow in our models, we've got to figure out what that team looks like and how we support that team around the longitudinal care continuous, not just around the primary care doc, but is that primary care doc have linear integrity across the entire longitudinal care, and that team also does that also. So I heard that loud and clear today, and so I'll add those comments. And any other comments from the team? Larry, you back on? Is he on mute again? Larry, you on mute?
Star 6. Star 6? Yeah.
Yeah. Walter?
Now, can you hear me now?
Yes.
I didn't realize I had to hit star 6 on my phone to unmute myself. Anyway, great discussion. I loved the afternoon session more than any of the others. Through the course of the morning and early afternoon, I felt, I was listening to people describe the elephant. And it just depended on what kind of a situation in which they were working in as to what their views were. But the afternoon session was a very scientific, and I came away with my major takeaway being, said at the end was that I wanted to, I think we should be looking at this as not specialty, but disease-specific solutions and disease and integration based upon disease. And I think that's what I was struck with in that last session between Mark and François and Rozalina. People have to be attributed and then sub-attributed, and buckets of risk have to be created based upon disease-specific nuances, and then you bring in you pay the specialists and the primaries based upon what services you want. I thought that was a fantastic session. It's going to make me, it had my gears spinning, and it's going to make me think on it. I listened to what a lot of saying, and, this albatross called CMS, they got to start moving on things, or else they're basically going to be, watching Rome burn, because everybody around is going to be developing in the absence of leadership from CMS. So I certainly hope that what we come up with does impact change and that we can see some forward movement. But the science is certainly there. And with the right data, and data is critical here, with the right data, we can come up with models and solutions for deployment. Great meeting.
Yep. Thank you, Larry. Walter?
Yeah, I also thought it was a great meeting, and I'm still processing a lot that was said. But I'd like to just offer something that's probably very controversial and play devil's advocate here, right? Because we heard about all the complexities of trying to integrate specialty care into total base cost of care and find the ideal payment model to do that. I've come away from today thinking it's not out there. I haven't heard anything yet in terms of a good way to engage specialists in total cost of care and kind of help them share in the savings. And so I'm left wondering, maybe the status quo is okay. Maybe we still have specialists kind of work off of a fee-for-service RVU system and have the risk-bearing entity be at the at the organizational level through the primary care provider, and let the primary care provider decide through his or her referrals how to manage specialty costs. I think Rozalina did a great job of going through all the complexities of attribution, and then I think Lily Rillstein mentioned you keep it simple, right? Keep it simple, and I think if we just have one accountable entity, and I think that's naturally the primary care provider for a variety of reasons, maybe that's enough. And I think perhaps Ann Greiner might have been kind of hinting at that through her comments in the very first session this morning, especially as she talked about some of the ways other countries are approaching this. Maybe I'm reading too much into that, but in any case, just to offer a kind of counterpoint to everything we're doing today.
Thank you for those. Any other comments? Well, if not, I think that's the end of the meeting, and we'll adjourn. For the first time today, we'll do the gavel. Adjourn. Okay. Thank you all. We'll see you tomorrow.
Produced by the U.S. Department of Health and Human Services.